we're going to talk about over the next 45 minutes a topic which is dear to my heart, which is acute kidney injury in the cancer patient. These are my disclosures. So we're going to try to answer 4 basic questions relevant to this topic. We're going to ask, how common is acute kidney injury in the cancer patient population? What does acute kidney injury mean for cancer patients? How do we approach AKI in cancer patients? And we'll spend the majority of our discussion going through some cancer-specific causes of AKI. So let's first ask, how common is AKI in cancer patients? And the bottom line is it's very common. So this is a large population study from Denmark that looked at about over 1 million patients, of which about over 37,000 were diagnosed with cancer during this time interval. The 1-year risk of AKI was about 18%, and the 5-year risk was almost 30%. The highest 1-year risks were seen in particular patients with kidney cancer, multiple myeloma, and liver cancer. It turns out that there are certain cancer patients that are at higher risk for AKI than others. For instance, patients who are critically ill. The incidence of AKI in these patients can be as high as 32% in this particular study from Brazil looking at a medical surgical ICU. About a third of these patients required dialysis. Hospital mortality was about 64%, 6-month mortality 73%. So you can see significant consequences there. Patients with hematologic malignancies represent another population that's at high risk for AKI. This is a study looking at 200 patients with high-grade hematologic malignancies. The rate of AKI here, using rifle criteria, was almost 70%, of which half of these patients required renal replacement therapy. And importantly, when they looked at this population, about 15% of patients, because of their AKI, actually received subtherapeutic doses of chemotherapy. Compared to patients who did not have AKI, you can see that the 6-month complete remission rates for cancer were lower, and the rates for mortality were higher among these patients. Patients who've received a hematopoietic stem cell transplant represent a third population that's at higher risk for AKI than standard cancer patients. You can see here that the risk of AKI ranges from 23% to as high as almost as greater than 75%, depending on the type of stem cell transplant. And we'll talk about this more later on in the talk. Patients who've had a stem cell transplant who develop AKI also have a higher risk of chronic kidney disease. As you can see, if we look at long-term survivors of a transplant, developing AKI increased the risk of developing CKD by almost 2-fold, and the cumulative incidence of chronic kidney disease in these patients is about 34% at 10 years, with AKI being a strong independent risk factor. So what does AKI mean for cancer patients? Essentially, development of AKI in cancer patients translates into higher rates of mortality, higher costs of hospitalization, lower rates of remission of their cancer, as you can see, and this may be due to the suboptimal dosing that these patients get because of their renal impairment, and a higher risk of developing CKD. So how should we approach AKI in the cancer patient population? Well, in general, we approach AKI in the cancer patient population almost the same as you would in the non-cancer patient population, in a systematic way in which we divide etiologies by pre-renal, intrinsic renal, and post-renal causes, because many of the same causes that affect non-cancer patients affect cancer patients as well. However, we have to be aware of specific etiologies that are specific to the cancer population, and we'll talk about these in more detail. So this is just some data from that study of ICU patients that developed AKI. As you can see, the most common causes of AKI in this patient population were common causes in the ICU: ischemia, shock, sepsis, nephrotoxins, obstruction. You can see that many patients had more than one etiology for their AKI. But in addition to these, you see other things like nephrectomy, tumor Lysis syndrome, multiple myeloma, and so forth. Chemotherapy is a significant cause of AKI in this patient population. And while chemotherapy is a topic of its own, and we won't necessarily be able to talk in detail about all these different agents, it's important to realize that as the armamentarium of cancer agents is continuously growing, we need to be aware of the agents that are associated with nephrotoxicity. As you can see, chemotherapy can affect essentially any compartment of the kidney: the vasculature, glomeruli, the tubules, and the interstitium. And there are drugs that have specific toxicity to these different regions. This is just for your update. I put together this list of drugs as of this year. These are some of the more recent drugs, targeted therapy agents, which have been found to be associated with nephrotoxicity. You may have heard that in the last year, there's a lot of press around these new agents called checkpoint inhibitors or immunotherapy, which have been used with a lot of success in patients who've had difficult to treat melanoma. And as it's been, now it's expanding its use outside of melanoma to other cancers such as lung cancer, renal cell carcinoma, and so forth. And I expect that we're going to see a lot more patients coming in potentially with nephrotoxicity. These drugs, these checkpoint inhibitors, ipilimumab and nivolumab, have been found to be associated with an acute interstitial nephritis in a proportion of patients. So let's talk now about some of the cancer-specific causes of AKI, and we're going to do this in a case-based format. So here's the first case. Here's a 65-year-old woman with a history of B-cell chronic lymphocytic leukemia, not on chemotherapy, who presented with a rise in creatinine from 1.1 to 3.4 over a period of 2 weeks with a white blood cell count of 94,000. She had a renal ultrasound which demonstrated large-sized kidneys. She had a kidney biopsy, and this is what the biopsy showed. As you can see here, there's a population of cells which have infiltrated the parenchyma of the kidney and essentially is completely distorting the architecture. If we look more carefully, we see that this is a mononuclear cell infiltrate. Again, you can hardly see any tubules around here because the cell population is really distending the interstitium. When these cells are stained for the B-cell marker CD20, you can see that all these cells are positive for CD20. The diagnosis on this biopsy was diffuse large B-cell lymphoma with parenchymal infiltration. So this gives us an opportunity to talk about lymphomatous or leukemic infiltration, which is a common but under-recognized complication of hematologic malignancies. So in one of the largest studies looking at patients with malignant lymphoma, looking at autopsies and biopsies, it turns out that almost a third of patients, or more than a third of patients with lymphoma, actually have lymphomatous infiltration of the kidneys, meaning they have lymphoma cells that infiltrate into the parenchyma of the kidney. In most cases, about 3/4 of cases, the infiltration is in both kidneys, and about 1/4 is only in one. And only about 15% of these patients are actually diagnosed before death. So a lot of this is under-recognized. These patients can present with AKI or proteinuria. And on imaging, some of these patients present with bilateral symmetric enlargement of the kidneys. Some may also have a localized mass or masses in an otherwise normal appearing kidney. So how does lymphomatous infiltration induce AKI? Well, there are a couple hypotheses. One is that the interstitial infiltration of these cells increases the pressure in the interstitial compartment, which can cause compression of tubules. It can cause compression of the vascula, leading to ischemia of the tubules as well, and modulation of tubular glomerular feedback. In addition to that, there may be some intraglomerular infiltration, which can resemble an acute glomerulonephritis. Here you have leukemic or lymphomatous cells, which are in the capillaries, can cause an obstruction to glomerular circulation. Some of these lymphoma cells can also secrete cytokines, which can increase the glomerular permeability and lead to the proteinuria that can be seen in some of these patients. So what is the management of lymphomatous infiltration? Well, essentially, if you treat the lymphoma, you treat the lymphomatous infiltration. So this is the patient that I presented to you here. You can see here's the patient's creatinine. The time of biopsy was about 3.4. At the time of biopsy, the patient was then treated with chemotherapy with fludarabine and rituximab, and you can see that over the next 8 months or so, the creatinine decreased. It did not decrease back to normal, which is commonly the case in these patients. So these patients, even with treatment, can develop residual kidney impairment and chronic kidney disease. I just want to make you aware that there are other forms of kidney impairment that can occur in patients who have lymphoma. So things you want to consider are obstruction. So if you have large retroperitoneal lymph nodes in patients with lymphoma, this can cause ureteral obstruction, hypertension, urate nephropathy or tumor lysis syndrome, hypercalcemia, radiation nephritis in those patients who receive abdominal radiation, and paraprotein-related diseases, which I'll talk about in the next lecture. So here's a second case. Here's a 59-year-old woman with a history of IgG lambda light chain multiple myeloma, not on treatment, who presents with nausea, vomiting, and loose stools. She developed these symptoms shortly after eating a seafood dinner. She said that she was not able to take in much food, but was able to drink fluids at home. She denied any hematuria or foamy urine, no NSAIDs or IV contrast exposure. She did receive a dose of zoledronic acid for bone protection 1 week prior to her presentation. Her past medical history was just notable for myeloma and osteoporosis. You can see her medications were pretty much unremarkable except for the zoledronic acid. On physical exam, she was hypertensive. Her pulse was 72. She had dry mucous membranes, normal JVP, and the rest of her exam was relatively unremarkable. However, her lab tests were not unremarkable. As you can see, she had a metabolic acidosis. Her creatinine was up to 11 from a baseline of normal. She was hyperphosphatemic and hypocalcemic. Her UA showed some protein, no red blood cells, and rare epithelial cells. And she had a serum-free light chain assay, which showed a profoundly elevated lambda light chain concentration of over 1,200 and a capital light chain ratio that was abnormally low at 0.03. We aggressively hydrated this woman with isotonic sodium bicarbonate because of her metabolic acidosis. Unfortunately, she did not recover her renal function. Her creatinine peaked at 11.5. She became progressively more uremic and was started on dexamethasone to help reduce her light chain load. And hemodialysis was started on the third hospital day. Here's her kidney biopsy. As you can see on these two cores here, that there's already significant changes you can see even at low magnification. Here you can see that there are multiple tubules which are dilated and atrophic, and the tubules are full of pale eosinophilic substance. The glomeruli appear relatively normal. You can also see there's an interstitial infiltrate. Here's a higher magnification showing you some of these distended and atrophic tubules full of this substance. Immunofluorescence showed positive staining for lambda light chains within the tubules, within those casts that we were seeing within those tubules, and negative kappa light chain. So it was a monotypic lambda stain. And this is electron microscopy showing you the lumen of one of these tubules. You can see this is the substance that's present within the tubule, the cast, and it has a sort of crystalline fractured appearance. Diagnosis here was lambda light chain cast nephropathy, formerly known as myeloma kidney, as well as the presence of some active interstitial nephritis. So this case offers us the opportunity to talk a little bit about AKI in patients with multiple myeloma. So AKI is one of the most common complications in patients with myeloma. About half of patients with myeloma will develop kidney disease at some time during the course of their disease. AKI is present in almost a quarter of patients at the time of presentation. Patients who have myeloma and kidney impairment have higher early mortality and worse survival, and unfortunately, AKI reduces the therapeutic options for these patients. Now, interestingly, however, patients who develop AKI and recover from AKI have a similar prognosis to patients who never developed AKI to begin with, just emphasizing the importance that if we can treat the AKI effectively, these patients actually have pretty reasonable outcomes. So the spectrum of kidney disease and myeloma is quite broad. We can actually divide the different diseases by presentation, either acute kidney injury or more of a subacute chronic course. Cast nephropathy is the most common cause of AKI in patients with myeloma, followed by other causes such as ATN, nephrotoxins, volume depletion, hypercalcemia. Rarely, treatment with bisphosphonates or hyperviscosity can cause AKI. The subacute causes are more like monoclonal immunoglobulin deposition disease, which we'll talk more about in the next lecture, amyloidosis, Fanconi syndrome, and occasionally infiltration of plasma cells into the kidney. So to understand the pathogenesis of cast nephropathy, we have to understand the physiology of how light chains are processed by the kidney. So light chains are relatively small in size, they're freely filtered by the glomerulus, and when they enter into the tubular space, they're actually taken up by proximal tubule cells by receptor-mediated endocytosis through this cubolin-megalin complex. Once they're endocytosed into the cell, the light chains in the endosomes fuse with lysosomes and are broken down and then recycled to the rest of the body. Now, in patients who have monoclonal gammopathy or myeloma, there's an excess production of these light chains, and the excess filtration of these light chains presents a load to the proximal tubule that the proximal tubule just can't handle. So the light chains overwhelm the proximal tubular capacity to reabsorb the light chains, and then they travel further down to the tubular system. When they get to the distal tubule, they enter an environment which actually favors the formation of casts. So what happens is these light chains actually interact with TAM-Horsfall protein, and it's been shown that there's an actual interaction site between the light chain and the TAM-Horsfall protein. And also the pH of the environment here enables precipitation of the light chains with TAM-Horsfall protein and cast formation. This causes tubular obstruction, leading to a backflow of urine, which decreases GFR. In certain patients, the pressure buildup from the cast formation can be high enough that the tubule actually ruptures. The light chains spill out into the interstitium, and this can lead to the development of some interstitial nephritis, which is often seen in these patients as well. So it turns out that light chain cast nephropathy is a disease of tumor burden. It occurs in patients who have a significant tumor burden in myeloma, meaning a significant light chain load. The development of cast nephropathy is generally seen in patients who have a light chain, abnormal light chain concentration greater than 1,500 milligrams per liter. If the concentration of light chains, of abnormal light chains, is less than 500, a diagnosis of light chain cast nephropathy is a little bit less likely. Factors that can enhance cast formation in the tubule include the sodium concentration in the tubule, the calcium concentration in the tubule, a decreased urine flow, which can be seen in patients who are volume depleted, as well as loop diuretics. The treatment of light chain cast nephropathy really revolves around two principles. The most important principle is that you want to reduce the light chain load that's being presented to the tubules. There's some data that shows that if you can reduce the light chains, the serum-free light chain load by 50 to 60% within 14 days of diagnosis, you actually have an 80% chance of renal recovery. The second principle is that we want to try to correct any potential factors that could be precipitating cast formation within the tubules. So let's talk first about the treatment of these precipitating factors. Volume depletion is a common cause or precipitating factor for cast nephropathy, so correction of volume depletion with IV fluids is paramount. We generally aim to increase the urine flow rate to at least 3 liters per day in these patients and giving them IV fluids. The recommended IV fluid is half normal saline, and the reason for this is because remember that the sodium concentration within the tubule, a higher sodium concentration is actually a risk factor for precipitating cast nephropathy. So you don't want to give patients normal saline unless they're really truly volume depleted and require that. So half normal saline may be a better way to prevent the development of volume overload in these patients. Correction of hypercalcemia is another measure that you want to address in these patients because hypercalcemia is also common. I won't go specifically into the treatment of hypercalcemia, but these patients are generally treated with volume IV fluids, bisphosphonates if necessary. Again, you want to be cautious with the use of loop diuretics in these patients because loop diuretics can also precipitate cast formation. So reducing light chain load really revolves around two things. One is chemotherapy. So if you want to reduce light chains, these patients have to be treated promptly with chemotherapy. And fortunately, within the last 10 years, there have been advances in the treatment for myeloma, such that most patients these days receive a regimen that includes a combination of bortezomib, which is a proteasome inhibitor, and high-dose steroids such as dexamethasone. Lenalidomide is another agent which is sometimes used in adjunct, and some patients still receive agents such as melphalan and thalidomide and cyclophosphamide. Chemotherapy is quite effective at reducing light chain load, and especially in patients with renal impairment, chemotherapy has been shown to be safe and effective in treating these patients. The other form of removing light chains or reducing light chain load is extracorporeal removal. These methods include things like plasmapheresis and high cutoff dialysis. Now, the use of plasmapheresis in patients with light chain cast nephropathy remains controversial. There have been a few randomized controlled trials, the last of which was performed actually over 10 years ago, so we're actually in need of a more recent trial, which have looked at patients with AKI and myeloma. And unfortunately, none of these data provide compelling evidence for or against the use of plasmapheresis in patients with cast nephropathy. Now, the largest study, which was the most recent one in 2005, showed negative results, that there were no differences in the composite endpoint of ESRD or worsening renal function in these patients. Unfortunately, this study was actually flawed by a number of factors. One is that it wasn't clear that all the patients in the study had cast nephropathy or could have benefited from plasmapheresis. Secondly, none of the patients had serum-free light chains to guide therapy, so you couldn't tell that the plasmapheresis was actually removing light chains effectively in these patients. And thirdly, patients during this era were not receiving the same types of chemotherapeutic agents that they would receive now. So whether we can translate these findings into current practice is questionable. However, there are some more recent retrospective studies that suggest that plasmapheresis may be of benefit in some subpopulations of patients with myeloma, particularly those who have biopsy-proven myeloma cast nephropathy or are highly suspected of having cast nephropathy. And if you can successfully reduce light chains, serum-free light chains by more than 50%, as I showed you before, these patients tend to have a pretty good chance of renal recovery. So patients for whom you might want to consider plasmapheresis, those who have biopsy-proven cast nephropathy, or those who have very, very high levels of serum-free monoclonal light chains in the serum or urine, highly suggestive of a diagnosis of cast nephropathy, even without the presence of a biopsy. One thing to remember when you're doing plasmapheresis is that plasmapheresis should never be performed in isolation. If a patient receives plasmapheresis, they should definitely be receiving chemotherapy at the same time, because plasmapheresis will do nothing to limit the production of light chains. It only helps to reduce the current load of light chains. So all patients, if you're considering plasmapheresis, need to be receiving chemotherapy concomitantly. Here's a third case. 45-year-old woman with a history of relapsed acute myeloid leukemia who presents with a white blood cell count of 129,000, most of which were blasts, who was admitted for treatment with hydroxyurea. A day after treatment, her creatinine increases from 1.1 to 2.7, and nephrology is consulted. Her past medical history is notable for mainly AML. Her medications were unremarkable. On exam, she was low-grade fever, she was tachycardic, her blood pressure was normal. She appeared chronically ill, pale mucosa, but the rest of her exam was relatively unremarkable. Here are her labs. As you can see, her creatinine had increased at this point to 3.7. She had a metabolic acidosis. Her phos was 7.4, calcium was 7.2. She had a uric acid level of 8.5. Her lactate dehydrogenase was elevated to 10,000. And her white blood cell count was 34,000, down from 129,000 just the day before. Her platelet count was 13,000. Her UA showed a little bit of blood and protein, but was otherwise unremarkable. This patient is representative of tumor lysis syndrome. So tumor lysis syndrome also is another common cause of AKI in the cancer population. It's a constellation of clinical and lab findings that result when treatment with chemotherapy causes death to tumor cells and the release of intracellular contents out into the serum. This leads to the findings of hyperkalemia, hyperphosphatemia with secondary hypocalcemia, hyperuricemia, and acute kidney injury. Tumor lysis most commonly occurs after the treatment of hematologic malignancies like ALL, AML, or Burkitt's lymphoma, but can actually occur after treatment of even solid tumors or any kind of bulky or rapidly growing tumor. And in some cases, spontaneous tumor lysis syndrome has also been reported. We now have criteria for the diagnosis of tumor lysis syndrome. These are called the Cairo-Bishop classification system, based on primarily laboratory criteria. So these criteria state that if you have more than 2 out of 4 of these lab criteria within a 24-hour period, either within 3 days before or 7 days after initiation of chemotherapy, you have a diagnosis of tumor lysis. So hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia. A clinical diagnosis of TLS includes the lab criteria plus one of the following, so AKI, cardiac arrhythmias, or seizures, tetany, or hypocalcemia. Again, there are certain types of cancers for which the risk for tumor lysis syndrome is much higher. And these are typically these high-grade hematologic malignancies. So you can see B-cell acute lymphoblastic leukemia, Burkitt's lymphoma, high-grade AML where the white blood cell count is over the 75,000. You can see the incidence of TLS is quite high, between 20 to 30%. So again, the pathogenesis of tumor lysis syndrome is related to the fact that you have lysis of these tumor cells releasing intracellular contents, in particular DNA, phosphate, potassium, and cytokines, which are not normally present at high concentrations in the plasma. DNA gets broken down into purines and pyrimidines. Adenosine and guanosine are broken down and metabolized to xanthine and ultimately broken down to uric acid. Now, the development of tumor lysis syndrome is dependent on whether or not you get accumulation of these substances within the plasma. So if renal function is normal and you're able to excrete most of these substances in the urine, patients generally don't develop tumor lysis. But when patients have an impairment in kidney function and excretion of these substances is not as normal, they accumulate, and this can lead to the development of AKI and tumor lysis syndrome. So how do we manage tumor lysis syndrome? The most important thing is prevention. And patients who are at risk for tumor lysis syndrome all come in and they all get volume expanded. And the reason for volume expansion is that this improves renal perfusion, it improves GFR, and it helps to maintain a high renal clearance of potassium, phosphorus, and uric acid. We typically target patients should be given 2 to 3 liters of fluids, either IV fluids or oral fluids, prior to the start of chemotherapy. The recommendation at this point from expert groups is to give D5 quarter normal saline. And the reason for this is because a lot of these patients will receive steroids and are at risk for sodium retention and hypertension. And so the recommendation is to give a fluid that is relatively low in sodium content. However, patients who have volume depletion, for instance, may be a specific population in which you might want to use isotonic saline instead. You want to try to maintain a high urine output, 80 to 100 cc's per hour. If necessary, you can use loop diuretics, but you want to make sure these patients don't develop hypovolemia or don't have evidence of urinary obstruction. Hypouricemic agents are also important because it's uric acid which is really the cause of AKI in these patients. So let's just review quickly the metabolism of purines, which leads to the production of uric acid. Recall that purines, so adenosine and guanine, are broken down to hypoxanthine and xanthine, and it's this enzyme xanthine oxidase which breaks these down into uric acid. So fortunately, we have a drug, which I'm sure you're all familiar with, called allopurinol. Allopurinol is a xanthine oxidase inhibitor, and as a result, it prevents further production of uric acid. Unfortunately, allopurinol does nothing to existing uric acid within the blood. And the other downside to using allopurinol is that if you inhibit uric acid production, you increase the concentration of its metabolites, xanthine and hypoxanthine. And xanthine and hypoxanthine can also crystallize within the kidney and cause nephropathy. So that's a risk that is associated with allopurinol. So in patients in whom you want to actually rapidly reduce serum uric acid levels, we have another drug called rasburicase. Rasburicase is a recombinant urate oxidase, which is an enzyme which is not present in humans, but is present in most other mammals. And urate oxidase converts uric acid to the more water-soluble allantoin. So 1 dose of rasburicase can reduce uric acid levels within hours, and is a very effective method for lowering uric acid levels in patients who are at high risk or who develop tumor lysis syndrome. One little pearl that you want to remember, though, is that rasburicase, you do not want to use rasburicase in patients who have G6PD deficiency, because these patients are at risk for developing hemolytic anemia. So historically, there was rationale for treating these patients with urinary alkalization. And the rationale here was that by alkalinizing the urine, you actually favored the conversion of uric acid into the more water-soluble urate. While this is true, the unfortunate downside is that while you increase the pH, this also increases the precipitation of calcium phosphate. And we know these patients also have hyperphosphatemia, so these patients can develop phosphate nephropathy. Alkalemia can also result from urinary alkalization. And so at this current time, urinary alkalization is not routinely recommended in the treatment or prevention of tumor lysis syndrome. So in patients who are at high risk for tumor lysis syndrome, they should have intensive monitoring. All patients should get volume expansion. Patients should receive allopurinol. And if they're at high risk, they should receive rasburicase prophylactically to prevent TLS. If patients, in spite of prevention, if patients still develop tumor lysis syndrome, the treatment is primarily supportive, so intensive supportive care with close monitoring of electrolytes, renal function, trying to prevent or reduce dietary potassium and phosphate restriction. Patients should receive rasburicase to try to lower uric acid levels. And in patients who develop worsening acute kidney injury or electrolyte abnormalities which are unresponsive to medical management, renal replacement therapy should be considered. Let's move on to the fourth case. So this is a 40-year-old woman who was recently diagnosed with metastatic renal cell carcinoma. She undergoes a right nephrectomy and a resection of a tumor thrombus in the right atrium. Post-operatively, her creatinine rises to 1.6, but subsequently returns back to her baseline of 1.0. She's then started on chemotherapy with gemcitabine and sunitinib, which is a tyrosine kinase inhibitor. And shortly after starting this regimen, she developed hypertension. These graphs here show the course of her therapy. You can see that over a period of months, she started having a rise in her serum creatinine after treatment, as well as an increase in her level of proteinuria. So she was referred to us, and we referred her for a kidney biopsy, and this is what the biopsy showed. So this is a low magnification light microscopic image, and you can see here that tubules here look relatively normal. This arrow points to a small vessel which is completely occluded. This is one of our glomeruli. As you can see, this looks relatively hypoperfused. You have narrowing and occlusion of capillary lumens. Here's another picture of one of our glomeruli, and here you can see the presence of double contours and thickened glomerular basement membranes. Electron microscopy again showed narrowing of her capillary lumens as well as remodeling and duplication of her glomerular basement membranes. And this is just another EM showing an occluded glomerular capillary. So this patient was diagnosed with a chronic active thrombotic microangiopathy with severe arterial and arteriolar sclerosis and signs of glomerular capillary wall remodeling. So thrombotic microangiopathy is another common cause of acute kidney injury in patients with cancer. Thrombotic microangiopathy we can define as a spectrum of disorders characterized by 4 criteria: the presence of microvascular occlusions, thromboses, microangiopathic hemolytic anemia, thrombocytopenia, and variable end organ damage, commonly acute kidney injury. You're probably familiar with the idiopathic forms of thrombotic microangiopathy, TTP, and hemolytic uremic syndrome. But TMA is also something that's pretty common in patients with cancer. So we can actually break down TMA in patients with cancer into 3 broad categories. There's cancer-related TMA, which is TMA that's directly caused by the cancer or associated with the cancer itself. There's chemotherapy-induced TMA, which is related to the treatment of the cancer. And there's also stem cell transplant-associated TMA, which I'll talk about towards the end of the lecture. Cancer-related TMA and chemotherapy-induced TMA can sometimes be hard to distinguish from one another. But there are some factors which can help to distinguish between the two. For instance, patients with cancer-related TMA typically have very active cancer. Often these patients have metastatic disease, whereas those with chemotherapy-induced TMA often will have very little disease activity. Patients with cancer-related TMA often present with like full-blown TTP, whereas those with chemotherapy-induced TMA have more of a variable presentation. They can have what looks like an HUS, a typical HUS type picture. They may have also just a renal-limited TMA with hypertension, some proteinuria, and a little bit of an elevated creatinine. Sorry, there's a little stall here. So cancer-related TMA occurs most commonly in patients with solid organ tumors. So gastric cancer is the cancer that's most commonly associated with a cancer-associated TMA. So more than 50% of cases of cancer-associated TMA occur in patients with gastric cancer, but other solid cancers like breast cancer, lung cancer, and prostate cancer can also cause cancer-related TMA. Many of the patients who develop TMA are patients who have metastatic cancer. Chemotherapy-induced TMA we can actually also subdivide into 2 categories based on the type of chemotherapeutic agent. So there's type 1 and there's type 2. Type 1 chemotherapy-induced TMA is caused by more common chemotherapeutic agents such as mitomycin or gemcitabine, whereas type 2 are caused by the anti-VEGF agents or agents that are directed against vascular endothelial growth factor. Bevacizumab is one of the more common agents that you'll see in this category. And the reason why we categorize TMA into these categories is because the clinical course is different. So patients who have type 1 chemotherapy-induced TMA tend to have more of a delayed onset. There's usually 6 to 12 months of treatment before the patients develop TMA, whereas those with type 2, TMA can occur at any time after treatment, after a single dose, after multiple doses. Type 1 is generally dose-related, and the higher the dose, the greater the risk, whereas with type 2, there's no relationship between dose. Type 1 typically has a more severe clinical course, so these patients will often develop permanent and irreversible acute kidney injury and hypertension. They often have hematologic manifestations, whereas patients with type 2, the clinical manifestations often reverse after discontinuation of the drug. Although they do have hypertension and proteinuria, AKI tends to be a little bit less common in patients with type 2. The prognosis with type 1 is also worse. These patients tend to have higher mortality and a higher incidence of chronic kidney disease even after the drug is stopped, whereas those with type 2 often will have better survival and better kidney survival rates after discontinuation of the drug. This is just a table showing you some of the characteristic drugs which can cause type 1 and type 2. Again, type 1 chemotherapy-induced TMA is typically more common agents like mitomycin, gemcitabine. We all know that cisplatin can be a tubular toxin, but it's maybe less commonly known that cisplatin and all the other platinum agents can also be associated with TMA. Also, liposomal doxorubicin can cause a TMA. Again, type 2 are the drugs that are associated with anti-VEGF. So these VEGF antibodies, such as bevacizumab, all the tyrosine kinase inhibitors, which you can recognize these drugs by the suffix. They all have the nibs in their names, so sunitinib, sorafenib, and so forth. These drugs are also common offenders. And some of these immunotherapy agents as well can be associated with a type 2 TMA. The management is primarily discontinuation of the agent. So if you can identify which drug it is, stopping the drug should be the first goal of therapy. A lot of these patients are hypertensive, so you want to try to control their blood pressure, preferably with an ACE inhibitor or an ARB if they have proteinuria. There's really no data on the use of plasmapheresis in these patients, and there's no clear evidence of benefit, so I generally don't recommend the use of plasmapheresis for these patients. And there are a few case reports of refractory TMA which have responded to eculizumab or rituximab, so those are some other options that you may want to consider if you've tried conservative management and it hasn't worked. So here's the final case. Here's a 44-year-old man with a history of acute myeloid leukemia who's undergone a myeloablative allogeneic hematopoietic stem cell transplant and has a history of chronic graft versus host disease of the skin, who's referred to you for an evaluation of AKI with a creatinine of 1.5 and a new onset of proteinuria with 3 grams in 24 hours, as well as microscopic hematuria. His urinalysis revealed a few cellular casts. Some details about his stem cell transplant. His conditioning regimen consisted of Cytoxan as well as total body radiation therapy. He underwent prophylactic treatment for graft versus host disease with methotrexate and tacrolimus, followed by tacrolimus monotherapy. So he underwent a kidney biopsy, and this is what we found. So this here is a silver stain showing you that there's some chronic changes here. There's some interstitial fibrosis. Here's one of his glomeruli. And the glomeruli demonstrated thickening of the glomerular basement membranes, also with the presence of these double contours, which we saw in the biopsy of the last patient. Immunofluorescence showed granular staining of IgG within glomeruli, a little bit of C3 positivity as well. Staining for IgG isotypes demonstrated the positive staining for gamma 1 and gamma 4. Staining for kappa and lambda showed positive staining for both, so this was not a monoclonal process. In electron microscopy, you could see here's a capillary wall. You can see that there are actually some deposits, some electron-dense deposits, which are present in the glomerular basement membrane, which are subepithelial. So this patient was diagnosed with a couple things. First thing was that this patient was found to have membranous nephropathy, stage 1, most likely secondary, and possibly an expression of chronic graft versus host disease or systemic autoimmune process. There were possibly some tubular interstitial immune complexes, but the patient also had evidence of a healed or chronic thrombotic microangiopathy, similar to what was seen in our last patient. So this gives us the opportunity to talk about AKI in a stem cell transplant population. And when I train the fellows each year when they come to our hospital, I tell them that when you see a patient who's had a stem cell transplant, really the devil is in the details. You want to know a number of very important facts about how the transplant was done. So the questions you want to ask are, what type of stem cell or what kind of bone marrow transplant did they receive? Did they get an allogeneic or from another, cells from another patient, or did they get an autologous transplant, cells from themselves? What was the conditioning regimen that was used? Was it a myeloablative or a non-myeloablative? And I'll talk about these terms in the next slide. Did they get any radiation therapy? Are they receiving graft versus host disease prophylaxis? Are they getting calcineurin inhibitors, mTOR inhibitors, or methotrexate? So just to define a couple terms, Conditioning, for instance, is what is given to these patients before the onset of the transplant. The purpose of the conditioning is to really pre-treat the patient and remove as much of the marrow before the patients get their stem cell transplant. So the myeloablative and non-myeloablative conditioning regimens, the goals here are a little bit different. A myeloablative conditioning regimen aims to completely eradicate the disease in the bone marrow. These patients receive high-dose chemotherapy. Many of them will receive total body radiation therapy, and the goal here is, again, to eradicate all cells within the marrow, and because of that, these cells are dependent on the stem cell transplant for rescue. In contrast, patients who get a non-myeloablative conditioning regimen or a reduced intensity conditioning regimen receive less chemotherapy, and most of them do not get radiation therapy. Here, the goal is not to completely eradicate the marrow, but to remove as much of it as it can, allowing for some of the donor cells, which are given to provide a graft versus tumor effect to eradicate the residual disease. These less intensive conditioning regimens are more optimal for patients who are older, who have more comorbidities. So AKI is very common in the transplant population. As I showed you in one of the early slides, the risk of AKI can be as high as 75% in these patients. Most cases of AKI will occur within 100 days post-transplant, and the onset is a little bit earlier in patients who've had a myeloablative transplant. And the risk of AKI is dependent on the type of transplant, which is why it's important to ask what type they've gotten. So myeloablative transplants have a higher risk of AKI than non-myeloablative. Allogeneic have a higher risk than autologous. The causes of AKI post-transplant can be divided into early onset versus late onset. Most of the early onset causes of AKI happen when the patients are hospitalized for the transplant, and most of these causes are very common causes of AKI: sepsis, hypotension, hypovolemia, nephrotoxic agents. There's a particular entity called Sinusoidal Obstruction Syndrome, which is specific to this transplant population. The differential is a little bit more limited in patients who present later, with a later onset. These patients typically have thrombotic microangiopathy, calcineurin inhibitor toxicity, or nephrotic syndrome. So just a brief word about sinusoidal obstruction syndrome. This is also called veno-occlusive disease. This is essentially a presentation which looks very similar to liver failure. So these patients present with tender hepatomegaly, fluid retention, jaundice, and the pathophysiology of veno-occlusive disease is not completely well understood, but it's thought that the conditioning regimen that these patients receive causes damage to hepatic sinusoidal endothelial cells, which causes thrombosis of hepatic sinusoids and the development of portal hypertension. So these patients often look like they're cirrhotic and have hepatorenal syndrome. It typically occurs, again, after administration of high-dose conditioning regimens, so high-dose chemotherapy, total body radiation therapy. And the interesting thing is patients who get reduced intensity conditioning regimens do not get this condition. So it seems to be high doses of or higher intensity conditioning regimens predisposed to this condition. This is just a slide of a liver showing what sinusoidal obstruction syndrome appears like. You can see this vesicle congestion, some of these occlusions within the sinusoids. AKI develops in about half of these patients. Clinically, it's indistinguishable from hepatorenal syndrome, so these patients present with sodium retention, weight gain, edema, ascites. They have low fractional excretions of sodium, generally bland urinary sediments, although sometimes they can have some granular casts as well. The management here is typically supportive. You want to maintain sodium and water balance in these patients, use diuretics, paracenteses as needed for edema and ascites, and renal replacement therapy if the AKI is severe. In some centers, including our own, some oncologists will use defibrotide, which is this oxy-deoxyribonucleotide that has antithrombotic and profibrinolytic properties. And some of these patients will respond to the treatment with defibrotide. So TMA, which was present in our patient, is also a relatively common cause of AKI in patients with stem cell transplant. In patients who've had an allogeneic transplant, the incidence is about 10%. Other names for this, they used to be called bone marrow transplant nephropathy or radiation nephropathy, primarily because if you look at the biopsies of these patients and you look at biopsies of patients who have radiation nephritis or animals who have radiation-induced injury, the biopsies look very similar. It looks like radiation-induced injury. The onset is typically about 3 months or 100 days after the transplant. The pathogenesis is not entirely clear, but it's thought that the multiple factors contribute to the pathogenesis of TMA: chemotherapy, radiation, certain genetic factors, calcineurin inhibitors, an underlying procoagulant state. All these factors together may lead to the development of endothelial damage within the kidney and the development of TMA. The diagnosis can be sometimes challenging to make because these patients will often have anemia and thrombocytopenia to begin with, but certain signs such as high LDH levels, low haptoglobin levels, the presence of schistocytes on a peripheral smear can clue you in. Patients are commonly hypertensive. There are really two types of patients that have, or two different presentations. Some patients present with a mild form of disease. They have a subacute rising creatinine and develop a stable chronic kidney disease. There are another subset of patients who have a very virulent form of disease. They have very rapid progression of chronic kidney disease to end-stage renal disease and have high morbidity and mortality. A renal biopsy confirms the diagnosis, but is rarely performed given the risk of bleeding. The treatment is primarily supportive in these patients. If possible, we discontinue the calcineurin inhibitor because this can be an inciting factor, and we control blood pressure as well as proteinuria. The last thing I'll talk about is just nephrotic syndrome in these patients. So the patient that presented in our case did have membranous nephropathy. So about 4% of patients after a stem cell transplant will develop nephrotic syndrome. If you look at the biopsy of these patients, most patients will have either membranous nephropathy, which occurs in about 60% of cases, or minimal change. These cases are generally diagnosed about 8 to 14 months after a transplant. And interestingly enough, these cases typically evolve when patients undergo a decrease in their immune suppression for graft versus host disease. The pathogenesis is not well understood, but there's some people that believe that nephrotic syndrome post-stem cell transplant is a manifestation of renal graft versus host disease. Because a lot of these patients who do develop this have an underlying history of graft versus host disease of other organs, such as the skin or the liver or pharynx, and that as you decrease immunosuppression in these patients, this is often when you see the development of the nephrotic syndrome. However, there's others who believe that graft versus host disease is not responsible for the development of nephrotic syndrome. The management is typically restarting immunosuppressive medications. So if these patients were on high-dose steroids, they get put back on high-dose steroids. Patients who have minimal change will typically respond very well to high-dose steroids. Patients who don't respond to high-dose steroids can sometimes respond to rituximab. So I've had patients who develop membranous nephropathy post-stem cell transplant who do not respond to steroids, but they do respond to rituximab. Conservative management with antiproteinuric therapies, ACE inhibitors, and ARBs is also important, as is blood pressure control. So just to show you the patient that I presented, this is when he initially had nephrotic syndrome. He was treated first with steroids. He went into a partial remission and was stable for about a year, and then developed a relapse of proteinuria, again developed nephrotic syndrome, at which point we treated him with 4 doses of weekly rituximab, after which you can see over a period of a couple months, he went into complete remission, and to this day remains in complete remission. So I hope over the last 40 minutes or so, I've tried to introduce you to some of the basic concepts of patients with acute kidney injury who have cancer. The goals here really that I want you to take away: use a systematic approach in approaching these patients like you would with any patient with AKI, but be aware that there are specific etiologies of AKI that are seen in the cancer population. We talked about lymphomatous infiltration, which is very common but under-recognized in patients with lymphoma or leukemia. We talked about cast nephropathy being the most common cause of AKI in the myeloma population. We talked about tumor lysis being an oncologic emergency, and that the focus of treatment here is really on trying to prevent the development of tumor lysis. We talked about thrombotic microangiopathy, and we talked about AKI in the stem cell transplant population. So I've included some self-assessment questions which you can take away and look at after this course is completed. But I'm happy to take any questions, and thank you for your attention. So the question was, are you saying, is the development of membranous nephropathy in these patients with stem cell transplant related to age? That's a good question. Certainly in the population, I see mostly adults, and in adults, for sure, membranous nephropathy is the more common cause of nephrotic syndrome in this patient population. However, I think the same is true in children who have stem cell transplant as well and develop nephrotic syndrome. So I don't think it's necessarily age-related.